Hello, friends, and welcome back to Dr. A. Sajid. Today we'll be talking about obstructive sleep apnea. If you haven't, before we begin off, if you haven't liked, subscribed the channel, we would really appreciate as it helps us grow. Let's talk about obstructive sleep apnea as per the NICE guidelines. Let's have a look. There's an O somewhere around here. Add the O first. Let's go. And if you have a look at the NICE guidelines, it starts off with the first topic, which would be the definition. And in terms of the definition, the NICE guidelines describes it as recurrent episodes of partial or complete sleep apnea resulting in daytime sleepiness. And so the definition itself is clear, but the presentation usually would be either a patient that walks into the GP surgery and will tell you that they wake up feeling tired, or they wake up as if they haven't really slept well, or they'll usually present with their partner, and the partner will book in the appointment and say that the patient snores too much at night, or there are episodes when the patient wakes up in the middle of the night gasping for air, but the patient doesn't remember, and the partner is the one who's more concerned. So it's a very nice case, mostly because it ties up the biopsychosocial aspect of the consultation very well, and how it's impacting the daily life of the patient, as most of the times the patients don't come in themselves and they're brought in by their partners. So that's the definition, and the risk factors are things that solidify the diagnosis, and these would be, number one would be perhaps obesity, and a middle aged, and most of the times it's a man, so a man who's middle aged and he's obese. Snoring is one of the complaints, and the NICE guideline talks about alcohol, smoking, and sedative drugs that could bring it out as well. Now, the presentation itself, like we've talked about, would more be from the patient's family, or the patient just waking up in the morning feeling tired. So NICE guidelines, they talk about considering OSA in patients who have two of the following, and the following include symptoms or presenting complaints. So snoring, that would be via partner, and then we'll have apnea episodes via partner. There could be waking up tired, waking up with a headache, or perhaps choking during sleep, or nocturia, or disturbed sleep. And if we were to get two of the following, we'd make the diagnosis for obstructive sleep apnea. Once we've heard the history and we're thinking along the lines, then as per our consultation, we'll start on the examination. And on examination, a few things that we would want the documentation to be there for would be the BMI, any jaw abnormalities, if there are any if there's any nasal obstruction, and we'd want to do a respiratory plus cardio examination. And possibly this is where we'll mention for ourselves to look into biopsychosocial aspects, because they would have the most impact on the patient with the presenting complaint, and we'd want to address them forwards as quick as possible. When we think about the differential diagnosis, we've pretty much ruled out most of them. So it's either there would be true symptoms of obstructive sleep apnea, or there would be something else that keeps the patient up at night. So it could be depression, for example, that could that basically means that the patient has difficulty switching off at night rather than not sleeping well at night and then waking up in the morning tired. Hypothyroidism with the tiredness could be another differential diagnosis. Drugs could be one of the reasons, a differential diagnosis to obstructive sleep apnea. And then the quality of sleep, so disturbed quality of sleep and quantity of sleep, so insomnia, both of them could be differential diagnosis as well. And in order to prove that the patient's not been sleeping well overnight, whilst on their end they think they have been sleeping, the best way to document in our history taking would be to put forwards an Epsworth snoring score. So this score itself is recommended by the NICE guidelines, and investigations are usually requested when it's greater than equal to 10. So it's a good thing to solidify. A patient, a male, obese, middle-aged man has come in with his partner who's complaining of excessive snoring and episodes where he can't breathe. You've had the history. You've come down to two of the 8 to 10 points that NICE suggests, and you want to solidify. Then putting an examination, you put down the BMI, and the BMI comes out as obese. You'd want to add the ESS score just to solidify your diagnosis even more. Because once the patient leaves, it's going to go forwards to the sleep clinic. So we'll not have much in our hands before that referral to solidify our diagnosis, and putting all of these things one after the other will help us just defend ourselves with this diagnosis a lot more. So those were the differential diagnoses. Now, given that we've established well along the risk factors and the history and the examination, and we've put forwards the ESS scoring, the diagnosis needs confirmation. And to diagnose as a clinician, you want to think along a few lines as to how you want to go forwards with it. You can either refer urgently to the sleep clinic. We can do a sleep study, which is routine. We can do a ENT referral, or we can do a PEDS referral. Now, in what situations do we do what? Urgent sleep referral is where our history taking skills would come most into play. If the patient has a driving day job, if the vigilance is critical for the safety of the patient, if they have an unstable cardiovascular disease, if they're pregnant, or they have they're undergoing a pre-operative assessment for major surgeries. So these are things that you'd want to look into the sleep clinic, urgent referrals. So this would mostly be via good history. Anybody who's got suspected will get an urgent sleep clinic referral. And sorry, anybody who's suspected OSA will get a routine sleep clinic referral. ENT referrals would be for patients where we're thinking along the lines of nasal obstruction through other stuff like polyps or sinusitis, or along the lines of any masses or any tumors around there. And then PEDS referrals would be for patients who have uh, similar symptoms, but they're children at the end of the day. So that's how the diagnosis itself is made. This should be read, I just realized. Let's put it now, no worries. So that's how the diagnosis is made. Next up, we've got the treatment, and the treatment pretty much lies in the hands of um, the specialist. And if you've referred someone for the sleep study, they'll see the specialist afterwards with the results, and they'll mainly be talking about the treatments either way. But if we were to be aware, and if the patient asks, it goes around three lines. We can either concentrate on weight loss and lifestyle modifications. We can look into mandibular devices, or lastly, we can look into CPAP. And most of the times, the gold standard diagnostic measure is the sleep study. Similarly, the gold standard treatment would be CPAP. There are a few drugs that are in trial with the NICE guidelines, but they haven't been approved yet. So hopefully we'll be seeing more of the drugs for the treatment, or perhaps reducing the frequency of apneas sooner or later. So that's my take on obstructive sleep apnea, the practical guide towards it. If the patient walks in, how do we pick it? If we've picked it, how do we document clearly that it stands firmly against our diagnosis? And then how do we refer it in the right direction? And hopefully the patient gets treated from that specialist referral. This is Dr. A. Sajid again. Please like, subscribe, and comment on my channel. And do let me know what topics you'd like to study on your end. Alright, guys. Bye.